I don't believe we're going to do that in this country. So we're going to see them one way or another. If you don't take care of yourself, if you smoke 4 packs of cigarettes a day, and you come to the ER, we're not going to basically not treat you. Unless, you know, if someone's suggesting that, that's intellectually consistent and intellectually honest, but that's not what we're doing, and no one suggested that. So it seems to me it makes much more sense to provide some kind of portable, basic benefits, not a Kadlec package, things that we know are important for people to be healthy and productive members of the workforce, and use our public resources to do that, and allow there to be a robust, competitive, private sector commercial insurance market for things above and beyond that. To me, it's much more cost effective than simply treating strokes rather than helping people manage their blood pressure. Unless someone wants to basically just let people die in the ER if they don't have coverage, and I don't hear anybody suggesting that. Yeah.
Thank you for coming, and I agree with everything that you've said, and I've actually lived a lot of this, so thank you. I'm a board-certified primary care physician, and I worked in the ER for 7 years. And one day I was jumping on a 42-year-old man's chest, and the nurse said, "This guy's not going to make it. Woman's crying, kids are crying." And I said, "This is the 3rd one this week. I named this body 20 years ago." And she said, "So go do it." So I've worked as director of Pac-10 universities. I've worked with street kids. I've worked in primary care. And I've been in the United States now for 17 years. So I know both systems because, like I said, I'm Canadian trained. What I tried to do was this triple aim 13 years ago, exactly that. And I can attest that even though it's thinking outside the box, people don't understand, but the patients do. And if you give them the choices to be educated, to have copies of all their records until we get them all into one site, they take their records with them. They know their stuff. And they don't go to the ER as much. They don't get as sick. And we work as teams. And the specialists, they say, "I don't quite know what you're doing, but whatever you're doing, keep doing it." And because they're doing outside their box, it's just not the medical care. We look at the culture, we look at their social, we look at all of that. My biggest problem is that the insurance companies, those who do support this, there is no code for it. And now a lot of the primary care docs are getting these audits where if you don't fill in the boxes with the acute care model, basically they can take you out very, very quickly. So we have health insurance, we have car insurance, but we have no insurance against these audits. So between the double whammy of Medicare not paying enough and the insurance doing these audits, those of us in the primary care who really care and love our patients are finding it exceedingly difficult. Last thing I'd like to say is I heard a presentation earlier this week with some out-of-the-box thinkers who are saying, let's just take the insurance companies and let them do what they've done well to take care of the catastrophic, the acute care, the downstream medicine. And let's move upstream medicine with this educational triple aim and take the insurance out and work in regional groups so that we don't have to spend the 41% on the paperwork, which is killing a lot of our practices. And so I am with that, and I would love to be part of the educational part of the primary care, and I'm really glad to have been here to hear this, and thank you very much.
Thank you.
Did you want to respond?
Well, I think the challenge here is to. It would be hard for me to appreciate this coming out of the U.S. Congress, but we do need fundamental, payment reform, and we need to create, I think, the incentives for the kinds of things we want to happen on the prevention and wellness side. And again, I think the best way to demonstrate that is to have some local leadership that's willing to sort of provide the catalyst for getting the different groups together to try to create this on a regional level. And I would say that, the same politics that cause gridlock in Washington, D.C. exist right here in this community as they do in Portland, Oregon. But I do think we're small enough and there's enough talent out there that if we could do, again, a demonstration project, we could begin to show very clearly the benefits of moving to that kind of primary upstream wellness model. Yes, sir.
Governor, thank you very much for your talk. In your information, you ascribed 55% of the cost in the system to lifestyle, behavior, and social influences. To me, that says we need to involve our schools, our churches, and our public health, and perhaps appeal to the independent that is not aligned with any of those to change their behavior. As an formerly elected representative, how would you help articulate the need to bring those divergent populations together with all the hot buttons that go with them when we need to focus on partnership? I, as a physician, can't do this alone, nor do I feel comfortable taking on risk for 55% of things that I really have no control over. How do I create the partnerships in today's world when I have limited time, resources, and a bully pulpit, so to speak?